This video will be an overview of urinary incontinence. The goals of this lesson are to go over the background, evaluation, treatment options, complications, and overall conclusions for urinary incontinence. Urinary incontinence is the involuntary leakage of urine. There are many different types of incontinence, including stress incontinence, urge incontinence, mixed incontinence, and overflow incontinence. The implications of these can be very significant on a patient's quality of life. It can cause work impairment, anxiety and depression, and sexual dysfunction. Risk factors include increasing age, obesity, multiparity, vaginal birth, and family history of incontinence. Let's delve into what each type of incontinence entails. Stress incontinence is due to an increase in abdominal pressure and the lack of mechanical support of the urethra. This lack of support can be for two reasons: urethral hypermobility or intrinsic sphincter deficiency. Urethral hypermobility is thought to be due to insufficient support of pelvic musculature, which can be due to chronic pressure or trauma during childbirth. Intrinsic sphincter deficiency is defined as a loss of intrinsic urethral mucosal and muscular tone from neuromuscular damage, which can be seen with nerve injury or neurologic conditions, or after prior pelvic or incontinence surgeries. Urge incontinence is defined as having an urge to void right before or during unintentional leakage of urine. It is caused by detrusor overactivity as there are involuntary bladder contractions during bladder filling. This can be caused by neurologic disorders, bladder abnormalities, altered bladder microbiome, or may be idiopathic. Mixed incontinence is a mixture of stress and urge incontinence. Overflow incontinence is the near continuous leakage of urine due to incomplete bladder emptying and is due to either detrusor underactivity or bladder outlet obstruction. Smooth muscle damage, peripheral neuropathy, and spinal cord damage can all cause detrusor underactivity. This chart shows the prevalence of incontinence by age and emphasizes that this is a common condition that is often underdiagnosed and undertreated. Having a broad differential diagnosis is important. Some conditions that may present similarly include urinary tract infection, fistulas, congenital abnormalities, functional conditions, or environmental and metabolic factors. At the initial office visit when a patient presents, you need to take a thorough history. Characterizing the incontinence can be done with a series of questions or questionnaires. Understanding the duration, precipitating events, severity, and impact on quality of life can change management. You should assess bladder storage symptoms such as frequency, nocturia, urgency, and incontinence, and bladder emptying symptoms such as hesitancy, slow stream, straining to void, feeling of incomplete emptying, and dysuria. Medications like diuretics can cause symptoms of incontinence. Having the patient keep a bladder diary for 2 to 3 days may be useful in determining if too much fluid intake may be contributing and provide a way to view symptoms over time. After getting a good history, a thorough physical exam and diagnostics are key. During the pelvic exam, you should exclude other pathologies. In those with prolapse, the prolapse can kink the urethra, so supporting and reducing the prolapse can actually reveal or worsen stress incontinence symptoms. In those complaining of stress incontinence, a cough stress test is the next best step. This can be performed in the supine position while asking the patient to cough. If no urine leakage is observed, the test should be repeated with the patient standing and with a full bladder. Assessment of urethral mobility should also be performed when evaluating for stress incontinence. When the displacement angle or the end angle of the urethral bladder neck is greater than 30 degrees, there is urethral hypermobility. A urinalysis should be performed routinely. A post-void residual is not required but can be helpful when the diagnosis is uncertain or if an incomplete bladder emptying is suspected. A rectal exam can be considered if there is a concern that fecal impaction is contributing to the incontinence. If initial office evaluation is inconclusive, urodynamic testing can be useful to further assess incontinence. It does not have to be done preoperatively if stress incontinence is uncomplicated, meaning post-void residual urine volume is less than 100 to 150 ml, there's a negative urinalysis result, a positive cough stress test result, or no pelvic organ prolapse beyond the hymen. Treatment options for all types of incontinence can vary from conservative measures to more invasive measures. Symptom control can be achieved with pads and PureWick, however, these treatments can be bothersome and costly. Treatments for stress incontinence include pelvic floor physical therapy, continence inserts or continence pessaries, or procedures such as urethral bulking or mid-urethral slings. For stress incontinence, the two main approaches of midurethral slings include retropubic and transobturator slings, such as depicted here. As always, there are complications to look out for after a surgical procedure, including bleeding, infection, injury to surrounding structures, and urinary retention, among others. Treatments for urge incontinence include behavioral and lifestyle modifications, including bladder training, weight loss, and fluid management. Avoidance of caffeine and other dietary triggers is also first line for urge incontinence. Pharmacotherapy is second line and includes use of anticholinergic or beta-3 agonist medications. They can be prescribed after physical and behavioral therapy or can be offered as primary treatment. These medications reduce or inhibit involuntary detrusor contractions. Side effects to look out for include dry mouth and constipation. Beta-3 agonists lead to increased muscle relaxation and increased bladder capacity. Local estrogen can also be used. Third-line therapies include procedures such as intravesical Botox injection, which acts as a partial paralytic, sacral neuromodulation, or posterior tibial nerve stimulation. If these fail, then surgical options should be considered, such as augmentation cystoplasty, urinary diversion, or suprapubic bladder catheter. Mixed incontinence can be treated the same as urge incontinence with anticholinergics and beta-3 agonists. If this does not work, consider a midurethral sling to target the stress incontinence aspect. Lastly, to manage overflow incontinence, the mechanism by which overflow is occurring is important. If it is due to detrusor muscle underactivity, look for any medications that can cause this. If bladder outlet obstruction is the cause, surgery may be considered, if applicable. In a patient experiencing chronic urinary retention, a patient may be taught to perform clean intermittent self-catheterization. We will end with conclusions. Lifestyle modifications are first line and can significantly improve symptoms of urinary incontinence. At the first office visit, a good history, physical exam, UA, demonstration of stress incontinence, urethral mobility assessment, and post-void residual measurement should be performed. Urodynamic testing is not necessary before surgery in those with uncomplicated stress incontinence. Synthetic midurethral slings have similar or better efficacy compared to that of suburethral fascial slings or colposuspension, with fewer adverse effects for stress incontinence. Finally, repair of pelvic organ prolapse may reveal or worsen stress incontinence and should be evaluated preoperatively and treated concomitantly for improved patient satisfaction. Thank you for listening to an overview of urinary incontinence.